So the more you treat, the longer it takes.
Okay, I have another question. Then, given what you just said about the procedure and how really if you don't do all of them, it really isn't effective, shouldn't that then be created as a standard in the field?
I totally agree, and that's a tougher problem to solve, is because there's so many doctors out there with very different philosophies and different tendencies. I scrub it with other cardiologists on doing like joint procedures, and I can see that all of us are so different. When I walk into a case, I want my field to be completely clean because I'm OCD. But when I look at other people, I mean, the field is all blood and wires everywhere, and so it made me realize that yes, we all went through the same training, but we all have such different tendencies and personalities. Yes, eventually I would say is we should have regulations to say that, look, if the patient has 5 good subarteries of a certain diameter, you should at least try to get to at least 4 out of 5. But the field is so new that we're not quite there yet. But I can see how someone can just treat 1 out of 5 and just call it an ablation because they don't want to deal with the other 4. Especially like for Rosa, there was one last one that took me a lot of just strategizing and using the equipment that I use for the heart to get to the kidney artery. So you have to do all that. But I totally agree. I think there should be regulation eventually. Thank you.
Don't be shy.
This is my favorite part about the talk, by the way. I love all the questions.
Free doctor visits.
I had 2 questions. Can you hear me?
Yes.
Okay. What is the selection criteria? And the reason I'm asking about that, my mom is up in age, but she has that dry cough. She's never been on any medications. She knows that she has atrial fibrillation. And then my second question would be, you want to answer that one first? Or?
What's the second question?
The second question would be, what happens after the operation? You insert that catheter, then how do you care for that catheter inside of your kidneys after the operation?
Okay. Great questions. Your first question is patient selection. Who do we choose? I think that's a really good question. The field is so new that, like I said, we haven't quite developed a criteria for choosing who we think would respond well to the procedure. We're still doing a lot of assessment and research to know which patient would do better. But the number one criteria is that your patient needs to be a resistant patient. So if the patient is doing well on 1 medication or even 2 medication, I think it's best to leave that patient alone. So you want to identify the resistant patients out there first. Number 2 is, if my patient has side effects from blood pressure medications, and there's a lot of them out there that have side effects, but yet they need to take these medications reluctantly, is because they know that they need to control their blood pressure. So I feel like the other types of patients are the ones that have side effects from blood pressure medications, and really their options are running low. I think those also are really good patients. I think as in terms of who will respond, we're very much still trying to figure that out. And hopefully by next year, hint, hint, if I come back to the talk, I will hopefully have more information for you guys.
And the second question was, what happened with the catheter once inserted in there?
Perfect, yes. So once we're done with the catheter is only to deliver radio frequency waves to those nerves around the kidney arteries. Once we're done, we take the catheter out, and I usually seal the hole in the artery with a plug, and the patient gets up after 2-3 hours.
Thank you very much.
Thank you.